Hey there. So we are live on our YouTube channel, and this morning we are teaching about our bariatric one-on-one seminar. This is the class that we provide in our program so that we can enter into the treatment options that we have here in our program for weight loss. And just a couple things about our program. We have been a center of excellence in bariatrics since 2006, so we've been doing this quite a long time. So if we jump right in to our objectives for today, we are going to define obesity. We're going to discuss all the treatment options that we have here in our program. We will review the risks and benefits from the different procedures. We will talk about the dietary changes that are necessary to make this a long-term solution. And then we're going to show videos here at the end so I can introduce you to all three of our bariatric surgeons. You can see a little bit of their personality, their philosophy, and if you choose to move forward with one of the surgeons with an appointment, then you can let us know if you would prefer which surgeon you would like to have an appointment with, or if you'd like to get in with the first available surgeon. Okay, so if we define obesity, obesity is defined as a BMI of 30 or greater, and BMI is just a simple calculation between your height and weight. We're happy to calculate that for you, or on your smartphone, there are several free apps where you can calculate your BMI. You just enter your height and your weight, and it will let you know what your BMI is. Okay. Another thing that we know about obesity is it's chronic, it's relapsing, it's multifactorial, simply meaning that there's more than one thing that leads to obesity. Some of those things may be psychological, immunity plays a role, there is a genetic component, environmental factors, the endocrine system, certainly the metabolism system, and there are some medical disorders that can lead to obesity as well. We do know that obesity can be driven by hunger hormones, and so one of those is ghrelin. Ghrelin is a hormone that is secreted in your stomach, and it's the hormone that makes you feel the sensation of that you're hungry and that you're craving something. Leptin, on the other hand, is the satiety hormone. So it is secreted and it allows your body to feel satisfied and full and content. And what we know in obesity is there can be a mismatch of these hunger hormones. And for instance, ghrelin may have an overproduction, and that can be leading to obesity. In 2013, the American Medical Association officially did define obesity as a disease, and as such, it means that we need to have a treatment option for it, just as we would any other disease. And so it did help to decrease the stigma of obesity in the medical community, but it also pushed some of the insurance companies to begin offering and covering treatment options for obesity, which was huge. Another thing that it did for diabetic patients, for type 2 diabetes, is it helped us to increase the awareness that we can put type 2 diabetes into remission, specifically with the gastric bypass procedure. I love this slide because it really shows the effects of obesity on the entire body. It really does impact every system of the body. So if we start here at the top psychologically, we see a lot of patients that struggle with anxiety, depression, body image issues. Some people are struggling with relationship issues that can be a side effect sometimes. Pulmonary wise, we see a lot of patients with sleep apnea, with asthma, in the heart, the cardiovascular system, high blood pressure, high cholesterol, coronary artery disease. We see a lot of females that struggle with infertility, polycystic ovarian syndrome. Certainly diabetes starts to creep in as well, which then can impact the renal system or the kidneys. Some of the other things would be an increased risk of gallstones, non-alcoholic fatty liver. It really does impact every system of the body. And then as the BMI begins to get higher, we also see a lot of patients that complain of back pain, joint pain, muscular pain. When we look at the spectrum of the BMI for patients, it helps us to understand how severe obesity is and how it's impacting the patient's overall health. So as I said, a BMI of 30 is the definition of obesity. When we hit a BMI of 35, with a health condition related to obesity. That's many times when insurance companies will begin to cover weight loss surgery in particular. To put things in perspective, here in Georgia, our obesity rate is between 30 to 35% for the entire state. So it is definitely an epidemic, not only in Georgia, but across the country. When someone reaches a BMI here of 40, you notice now that we've got the word morbidly obese in there. Morbidly just means that it can impact the patient's lifespan, and it can cut years off of that patient's lifespan, likely due to other chronic diseases that are related to obesity. And that's why we really want to treat obesity as the root cause, so that we can impact the other disease processes that come along with that. So here I'd like to pause for just a minute and talk to you about several different options that we do have available here in our program. The first one of those options is nutritional counseling. So we do have a registered dietitian who specializes in weight loss embedded here in our program. Her name is Giselle. You will meet her here shortly further on in this video. So Giselle meets with people. She's able to look at what your habits are on a weekly basis, and she's able to look at your food plan and be able to tweak and make some suggestions on some changes that you will be able to make to achieve some weight loss. And so nutritional counseling here in our program is a cash pay. A lot of insurance companies will not cover nutritional counseling in regards to weight loss. So our cash pay amounts are actually really low compared to where you may get in other areas. So for the first appointment with a dietitian, it's $60 for the 1 hour appointment. It's a very detailed and historical appointment, so she can understand your history, and you guys can make a very good starting plan. The follow-up appointments with a dietitian here in our program is $39, and so that's for the follow-up appointment. So that's the nutritional counseling piece. The second option that we have here in our program, just going to change where this slide is because I feel like it's glaring on our little screen behind me. It's still going to be there, isn't it? That's okay. The second option is medical weight loss with our bariatricians. So through the Longstreet Clinic and NGPG, we have several bariatricians that can help our patients. The bariatricians help with medical weight loss, and what they will do is they will work with the patient, sometimes using meal replacements. Sometimes they use some appetite suppressants, so some medications that can decrease the amount of hunger that you feel. And they can incorporate as well a dietitian to work alongside you. So if you've never had nutritional counseling or worked towards medical weight loss, these are the first two options that we have available in our program. The third option is something that's called the intragastric balloon. The screen behind me indicates that it is a non-surgical procedure. And so the intragastric balloon is a non-surgical option. So this is for somebody who maybe has already tried medical weight loss, already tried nutritional counseling, but maybe is not quite ready for surgical weight loss, or their BMI is not at a place to make them a candidate for surgical weight loss. So you see here the BMI is pretty low, on the low side of the spectrum of most of the patients that we see in our program. So it's limited for a patient between a BMI of 30 to 40. And this is a cash pay procedure only. Insurance companies are not currently paying for this option. Here in our program, depending on which balloon you choose, the cost for this procedure would be somewhere between $6,800 to $7,000, depending on the balloon type. It depends on which balloon. One is endoscopically inserted. The other is orally inserted. So we have two different types of balloons I'm going to go over here for you. So we have Orbera, which is endoscopically inserted. So that means that the patient would go to the endo suite. They would be sedated as if they're having an upper endoscopy. The surgeon would go down with a scope through the mouth down to the stomach, insert the balloon, and below that balloon up with saline. Holds about 500 cc's of saline, weighs about 2 pounds. The whole way, the rationale behind the way that the intragastric balloon works is that the balloon occupies a space in the stomach. Therefore, when the patient eats, they feel full off of smaller portions. They lose weight because they're not eating as much. The other balloon is called Obalon, and this one is orally inserted. This can be done actually in the doctor's office. So Obalon actually is a small capsule that the patient will swallow. So it's like taking a pill. They swallow that down to their stomach. there's a very thin tubing attached to that. When the surgeon is able to verify that that balloon is in the stomach in good placement, then he's able to blow that balloon up with air. So this one is lighter feeling, and it's actually smaller to the point that the surgeon can add up to 3 balloons over time. Again, occupies space in the stomach, the patient feels fuller off of smaller portions and is able to lose weight. Now, either of these balloons are only intended and approved by the FDA to stay in for 6 months. It is a foreign object. It does increase the risk of gastric ulcers, which means that we have to give our patients medications to protect their stomach during this time. And so it only stays in for 6 months. The patient will work with a dietitian during the 6-month period on a monthly basis to work on meal planning, portion sizes. And then after the balloon is removed at the 6-month time, and both of them have to come out endoscopically, as I described before, then they will continue to work with a dietitian for the next 6 months to maintain that weight loss. So this is going to show you a video of Orbera. This is the one that's endoscopically performed. So you'll watch this. I'm going to show you a sample of it as well. So this video showed how he went down with an endoscope. He filled the balloon up with saline. This part of the video here is showing you how it's removed. So it's going to be removed from the stomach. So this is just a stomach model, but this shows a balloon that's inserted inside the stomach. Okay, so it went down, surgeon dropped it in and blew the balloon up with saline. So that's the first option. That's the one that's called Orbera. Now, Obalon is the one that is a smaller balloon. So at the 6-month mark, these balloons will then be removed. And the patient will continue to work with a dietitian to maintain that weight loss. So some things to know about the intragastric balloon. Like I said before, our patients are at an increased risk of developing gastric ulcers. So we give our patients anti-ulcer medication to coat their stomach and to protect their stomach while the balloon is in place. Some patients do complain of nausea, specifically in the first 1 to 3 days after the balloon is inserted, simply because there is a foreign object in the stomach, so they get a sensation of that. And so we can give them an anti-nausea medication to help control those side effects until they pass. For most people, it does resolve after 3 days. Now, it is a 12-month commitment, again, working with a nutritionist while the balloon is in place and then afterwards. Monthly dietitian visits, a behavior coach, support group. The average amount of weight loss with this particular procedure is about 25% excess weight loss. And depending on the person and how particular they are with their food choices and portion sizes, that usually equals on average anywhere from 30 to 50 pounds. Okay, some potential complications in regards to the intragastric balloon would be managing the nausea and vomiting. If somebody is not able to have that nausea and vomiting pass or be relieved after the 3-day mark, and they continue to not be able to tolerate that, then that would be called intolerant. So hopefully we can manage the nausea, vomiting with medications in the first 1 to 3 days. Typically, majority of patients resolve that. If not, and they're intolerant of it, then the balloon would need to come out. Now, balloon failure or migration. This is a foreign object, so if this balloon were to pop, then it potentially could begin to go down and escape the stomach and go further down the GI tract. If that's the case, the surgeon would need to go in endoscopically, go down, get the balloon, remove it, and insert a new balloon. Okay, and we've already discussed the gastric ulcers. So now the rest of this talk is going to be focused specifically on surgical weight loss. So this is a picture of our North Patient Tower here at the Gainesville campus. While all of our providers do have offices in Brazelton and in Gainesville, our surgeries are only done here at the Gainesville campus because this is where we have our Center of Excellence. The staff here that help to care for our patients specialize in caring for patients after having bariatric or weight loss surgery. So they have had additional education. They've got a lot of experience in this, and this is where our Center of Excellence resides. And so just the surgeries have to happen here, but you can either have virtual appointments or you can see, your provider in Brazelton or Gainesville. So some things to know. Let's go ahead and discuss self-pay versus insurance. So my hope is that you will have insurance coverage for weight loss surgery. You can know that by calling the number on the back of your insurance card and asking specifically if you have coverage for bariatric or weight loss surgery, or we're happy to check your benefits for you here. So for most insurance companies, the patient has to have a BMI between that 35 to 39.9 with a health condition related to obesity. The most common conditions are sleep apnea, high blood pressure, high cholesterol, heart disease, acid reflux or GERD, or type 2 diabetes. These are the most common. However, if you don't have any of these, I would still encourage you to go forward with an appointment because we may find something else that maybe you didn't think of to report to us that could be in your policy approved. So for example, I've seen people get through with insurance with things like polycystic ovarian syndrome or fatty liver, or if somebody's never, for example, had a sleep study before, your surgeon may send you for a home sleep study. If you even have mild sleep apnea, that might be a condition that could get you approved through your insurance company. If a patient reaches a BMI of 40 or greater, many insurance companies will cover weight loss surgery because we know that the higher the BMI, the more likely the patient is going to develop these issues, because we know it's not a matter of if, but rather a matter of time before other chronic health conditions begin to come to reality. And that's why we really like to intervene early on. Okay, so this is the insurance option. Now, another thing to know about insurance and weight loss surgery is that we can have two different people have the exact same name of a policy. So let's just use Aetna, for example. I can have two patients who both have Aetna. One may have a health insurance coverage for weight loss surgery. The other may not. And it may be something called an employer exclusion, which means that the company overall looked at what they wanted to cover and they decided that they did not want to cover weight loss surgery because it made the policy premium cheaper for everybody in the program. So that's kind of how this works with insurance companies. It's similar to your homeowner's insurance, where you can elect to have flood insurance or not to have flood insurance. And if you elect not to, then it decreases your premium overall. So that's why we can't really tell you whether you have insurance to cover weight loss surgery or not just by the specific name of the company. It depends on the fine print in that policy. So some people already know that their insurance company does not cover. And so unfortunately in the state of Georgia, for our state health employees, they do not have coverage now. And this is something that we have been fighting through legislature for some years now. So if this is you, you're either a state health employee or you already know that you don't have coverage, then you may want to explore the self-pay option. So some things to know about this. We do have a couple of companies here, Prosper and Health Credit Services, that we do work with for medical loans. You can go to their websites, you can input your information, and you can go ahead and find out if you would qualify. These are dependent on your credit scores. Now, I've had other patients that have come to me through the years I've been doing this that have told me, Amy, my doctors told me that I'm going to die if I don't get my health under control. I've got to do this. Even if I don't have health insurance, I've got to do this. And so we understand that, and we want to help our patients in any way we can. I have seen patients take money out of their 401k to invest in this. I've seen people, again, take out medical loans. I've also seen some people be very successful through GoFundMe accounts. So there is a way to get it done. It does depend on the surgery that you choose, and we're going to go over those specifically in a little bit. But if you're looking for like the sleeve gastrectomy here in our program, the price is somewhere around $17,800. The gastric bypass is running somewhere around $20,000 currently. So just so that you're aware of the cost. So that does sound like a steep amount. However, when you're looking at your life and your quality of life, for some people, they're like, you know what, this is important to me. I'm going to take out a loan for myself. And so I have had many patients that have looked at it in that respect as well. Some benefits of being a self-pay option is you don't have to worry about jumping through the insurance hoops. You don't have to wait on the delays of insurance. So there's not a required 3 to 6 month diet, for example, that some insurance companies require. So you can get to surgery faster. We can potentially treat lower BMIs. And what I mean by lower is if we, you know how I told you a BMI of 35, if somebody's a self-pay and we don't have to adhere to the insurance regulations, if somebody, for example, maybe had a BMI of 33, but they had type 2 diabetes that the surgeon is pretty confident they can put into remission, then they would consider that patient as a good candidate for weight loss surgery. So the surgeon may consider other patients that maybe they would not be able to because of insurance regulations. So that is definitely an added benefit. And again, no extended wait times, so patients can get to surgery sooner than they would if they had to wait on the insurance criteria. Now, because we are a center of excellence, we are required to share our annual surgical volume with you. So in 2019, we had 88 patients that came to us for a sleeve gastrectomy. We had 105 patients that had the Roux-en-Y gastric bypass. We had another 50 or so patients that had other procedures that are not covered in this lecture. So here is the anatomy of both a normal GI tract and then someone who's had the sleeve gastrectomy. So I'm going to spend some time talking about the normal anatomy so that the rest of this lecture is going to make a lot more sense to you. So on the left-hand side, we have normal anatomy, and what we see here is the esophagus that then comes down into the regular stomach. At the base of the stomach, right here, we have a valve called the pyloric valve. As we normally eat, this valve will open and close. So it will close to allow the stomach to churn and for food to be digested, and then it will open to allow food and nutrients out to be absorbed in the intestines. So this will become important later. After that, we have the first part of the small intestines, which is called the duodenum. And then we have the second part, which is called the jejunum. So this is our normal anatomy, our baseline that we can have a discussion over. On the right-hand side, this is a picture of a patient that has had the sleeve gastrectomy. So the sleeve gastrectomy is a very straightforward procedure. The surgeon literally comes over to the stomach and he makes a line that goes like this, and he cuts away the greater curvature of the stomach while he staples. So here, and you may not be able to see it in this video, but right here, you may see the little bit of the edges, is the staple line. So the surgeon uses a stapler in the operating room that cuts and seals at the same time. So if you've ever heard of the food saver, right? So that's the machine if you're wanting to save food, and you put it through there and you push down the top of it and it cuts, but with heat, it seals off at the same time. Similar technology, okay? With the difference in surgery being that when he cuts and seals, he's sealing this off with 3 layers of staples here and 3 layers of staples on the other side of the stomach that he's going to remove. After that, he sutures, or uses stitches, and he hand sews over this staple line to reinforce it. The third layer of protection is something called tisial, And so he squirts Tisiol all along that incision line and he seals it off. So there's 3 layers of leak protection. So that is one complication that we worry about in bariatrics, which is called a leak. And I always compare this to plumbing. So you have a plumber come over, he takes pipes apart, he puts pipes back together, and before he leaves the house, he does a leak test. He wants to make sure that there isn't a leak in this area. So we do something very similar to that in the operating room. So after the procedure's done, he floods the abdomen with saline through a tube that's inserted in the patient's mouth. He injects air, and then the surgeon looks for a leak. He looks for little bubbles to come up, almost like checking a tire for a leak. So that's what happens in this case, and we're looking to make sure that we don't have a leak before we leave the operating room. So in a nutshell, this is the sleeve gastrectomy. It simply reduces the size of the stomach, cuts away about 80% of the stomach, and makes it smaller.
Sleeve gastrectomy is a restrictive procedure that limits food intake by cutting and stapling a thin vertical section of the stomach to make a smaller, narrower stomach pouch. The remaining larger portion of the stomach is then permanently removed. Unlike gastric bypass, there is no rerouting of the intestines. However, the sleeve gastrectomy involves permanently removing a large portion of the stomach.
Okay, so a couple things that video said was that there's no long-term studies. A couple things I like to address about this video. It is an older video, but it's animated, so it's not showing real, surgery, so it doesn't gross you out or anything. But it is very accurate, and so that's why I continue to use it. But when we talk about long-term studies, that is true that the sleeve gastrectomy does not have as many long-term studies, say, as the gastric bypass. The gastric bypass has been around 35, 40 years, depending on the area in the world that we're talking about, whereas the sleeve gastrectomy has been around more like 15 to 20 years. So it has been around a long time, but it has not been around nearly as long as the gastric bypass. Now, it is permanent. If we go back to our previous slide, which I'll have to find for us here, our previous slide here, if we look at this section of the stomach that he cut away, this section right here is completely gone. So that is a permanent change. It cannot be put back together. Okay? So that's the sleeve gastrectomy. It limits the amount of food that a patient can eat at once. Therefore, they feel full, they eat smaller amounts, and they lose weight. Now, something that we need to address right away is weight loss surgery is not a quick fix. Weight loss surgery provides the patient with a physical tool to lose weight. And the way that this works is utilizing this physical tool at mealtime. So, for example, the patient eats breakfast, and it should be something that's high in protein, okay? It's going to make the patient feel full, and then they're not going to eat again until the next mealtime, and they're going to drink their water, get their fluids in during that period of time. That's how a patient is successful, by not snacking throughout the day and only eating during mealtime. If someone were to snack and eat very frequently small amounts, then they're not going to utilize their tool correctly, and they're going to consume more calories than they should be getting in to be successful with the weight loss surgery, and they will either begin to not lose weight, or they would begin to regain weight after surgery. Okay, so that's how weight loss surgery is effective. Some things to know about the sleeve gastrectomy. There is no rerouting of the intestines. We simply decrease the size of the stomach, which, by the way that the sleeve gastrectomy came to be was many years ago, bariatric surgeons were looking at treating some higher BMI patients, some super morbidly obese patients, and they felt that they were not going to be able to sustain a longer procedure. They wouldn't be able to endure it. And so instead of doing the gastric bypass, they decided to just simply decrease the size of the stomach and do the first part of the procedure, with the intention of waiting for the patient after the sleeve gastrectomy to lose enough weight to safely be able to go in for the second stage of the procedure, which is rerouting the intestines for the gastric bypass. But what they found is that many patients were so successful with the sleeve gastrectomy, they didn't have to go back and do that second stage of the procedure. So that's how the sleeve gastrectomy came to be as a primary treatment option for obesity. It does decrease the production of ghrelin, that hunger hormone that we talked about at the beginning, because it is secreted in that greater curvature of the stomach that we're now cutting away and removing. And so for the honeymoon period in bariatrics, which can be anywhere from 6 to 12 months, depending on the patient may not feel hungry at all. They may have to look at their watch to know what time it is, to know that it's time to eat a meal. So that's something to be aware of. It does limit the amount of food that can be eaten at once. And the average excess weight loss for someone who's having the sleeve gastrectomy is about 50 to 66%. So let me put this in perspective. Everything that we are referencing statistic-wise is coming from the ASMBS. That is our national group, and that's where we can find our source of truth. So I always encourage people, go to the asmbs.org. That's where you're going to find the facts about bariatric surgery. Don't ever go to someone's blog or personal opinion and take that as fact. It's okay to listen to it, but you want to know what the facts are. So when we talk about the average excess weight, we have to remember that just like a classroom full of students, there are going to be some people that knock it out of the park. There's going to be some people that don't put forth much effort, and there may be some people in the middle that just kind of, squeak by. So that's how we get that average. Just like somebody taking a test, it's going to be an average of all of those people. So nationally speaking, 50 to 66% excess weight loss is what someone could expect with a sleeve gastrectomy. However, in my experience, I have seen people that have done very well with a sleeve gastrectomy that have achieved about 80% excess weight loss. So if we put this in pounds, and everybody's going to be different depending on how much excess weight you're carrying, but if we use 100 pounds as an average, and say somebody needs to lose about 100 pounds, then they realistically could lose 50 to 66 pounds in a year with weight loss surgery. Or like some of the patients that I've experienced, they could lose 80 pounds if they were very particular about their food choices and portions, and specifically not eating between meals. Now, some risks. It is not reversible. That section of the stomach is removed, can't be put back. There is a higher incidence of postoperative nausea and spasms. This is true. The stomach is very muscular, and even though it's a surgical intervention, it's still to the body is like an injury. And so as that section of the stomach is cut away, it's a very long incision line, and the stomach feels that as an injury. And so the stomach can tense up, it can have muscle spasms. The good news is it's short-lived, and we do have medications that we treat it with. We have a medication called Levsin that our patients could put underneath their tongue. It's a smooth muscle relaxant and allows the stomach to relax and not have as many spasms. We also have a whole protocol here in our program to prevent nausea, and then if someone still struggles with it, to treat it as well. Some other things to know is our patients are less likely to develop dumping syndrome in regards to carbohydrates, sugars, or fats. And we're going to talk more in particular with this with the gastric bypass, but just know that most patients with a sleeve gastrectomy do not have an issue with what they eat. They can still eat whatever they want, with the caveat if they need to be eating a high protein diet and eating some carbs, but limiting it so that they're able to maximize their weight loss. And that's where the dietitians are going to become very, very important in the program. So something to know about the sleeve gastrectomy is as the surgeon removes that section of the stomach, the part of the stomach that's left is very skinny. It's very tubular. It's like a sleeve, okay? And if someone already has acid reflux, okay, or GERD, if they have to take something every single day, over the counter or prescription for their reflux, this may not be the right procedure for you, because it's a tubular structure after surgery. And when that pyloric valve at the base of the stomach closes, it can cause a high pressure chamber, and it can make the acid go up, and it can actually make acid reflux worse. So this may not be the best procedure for you. So something to think about and something to talk to the surgeon about so that you can help to decide which procedure really is best for you. So we've already talked about the risk for developing a leak and how the 3 layers of protection and the way that we monitor for that. All of our patients are at risk for a gastric ulcer, just like with the intragastric balloon. But this is for everything for someone who's had weight loss surgery. So we do teach our patients that there are a few things that they need to be aware of and to avoid forever after weight loss surgery. One of those things is NSAID medications, non-steroidal anti-inflammatory medications. Those things could be like Motrin, Advil, Goodies powders, smoking, or alcohol. Those are things to avoid. Okay, those are things that would increase the risk of gastric ulcers. Now that I've mentioned alcohol, let's talk about that for just a minute too. For our patients who have weight loss surgery, they are required to stay away from alcohol for a full 1 year because it's made of sugar and it's going to work against your weight loss. Okay, but secondly, once you do hit that 1 year, you need to be very aware that your body will process alcohol in a very different way. And so when you do choose to have alcohol after surgery, after that 1 year, you need to be somewhere where you're safe with people that you trust and not behind the wheel of a car, because your body will absorb that alcohol very quickly. You will get a high reaction from that, and then it will go away quickly. And so regardless of why or how, if your limit is over the legal limit, you could get a DUI off of a very small, a couple sips. And so you need to be very, very careful with that. Now we're going to go ahead and focus on the gastric bypass, the Roux-en-Y gastric bypass. Some people call it just the bypass for short. So now that we have an understanding of the normal anatomy, it may make it a little easier for you to understand how the gastric bypass is done and how it works. So what we see here in this picture here is we have the esophagus here. Okay, it comes down to the top of the stomach where the surgeon has disconnected it and created a very small pouch. What the surgeon has done is he has gone down and he's actually grabbed the second part of the small intestine called the jejunum, and he has brought it up and attached it to the base of that pouch. So this stomach back here is the leftover, or what we call the remnant pouch, the leftover stomach. And you notice that he has sealed it off, but it stays in the body. And this leftover stomach still works. It still has nerve endings. It still has blood flow. It still secretes gastric acid. But now what he's done is he has reconnected the first part of the small intestine further down to the second part of the small intestine so that this acid can go down and it can aid in further digestion downstream. So now when the patient eats, drinks, takes medication, anything, it no longer comes in contact with the leftover stomach or the first part of the small intestines. So the patient eats, it goes through the esophagus, into the pouch of the gastric bypass, and then it gets dropped into the second part of the small intestine. So I'm going to show you a quick video on how this works.
Gastric bypass is a restrictive and malabsorptive procedure that results in fewer nutrients and calories being absorbed. It reduces food intake by cutting and stapling the stomach to make a small stomach pouch. The small intestine is cut and the lower section is directly attached to the new pouch. Food then passes directly into the lower portion of the small intestine, bypassing most of the stomach and upper intestines.
Okay, and so that talks about the gastric bypass. And again, that's an older video, but I think it's very helpful to explain how the procedure works. So some benefits of the gastric bypass. There is a smaller stomach pouch compared to the sleeve gastrectomy. There is an increased intolerance to carbohydrates, sugars, and fats. So that's kind of an odd statement because I'm telling you the benefits, in other words, the positives about the surgery, but I'm telling you something that sounds negative. So when we have patients that maybe struggle with food choices and maybe they lean towards eating sweets or foods that are greasy or high in fat content, this particular surgery can be helpful because it can give them the physical tool to teach them the types of foods maybe that's going to help to keep them on their weight loss journey. So let me describe what I mean by this. If someone with normal anatomy were to eat something that is high in fat or sugar, it's going to go through their esophagus into their stomach, into the first part of their small intestine where it's used to that concentration. And then it's going to be thinned out and the concentration is going to be diluted. And then it's going to be going down to the second part of the small intestine. The patient usually won't have any issues. However, after the gastric bypass, it's very different. If someone consumes something that's high in fat, high in sugar, it will go down the esophagus, into the pouch, and then it's going to be dropped in the second part of the small intestine where it's not used to that concentration at all, and it doesn't like it. So it pulls fluid from the outside inside. The intestine begins to swell. The patient's going to develop abdominal cramping, and they're going to run to the restroom and either have diarrhea or vomiting. Now, we look at that as a positive because we're here to treat obesity and all those other chronic conditions. And so for patients that struggle with that, if they were to develop dumping syndrome, they may do it once, they may do it twice, but eventually they're going to develop a aversion to eating those types of foods because they know what it's going to lead to. Now, having said that, in working with patients for many years in bariatrics, what I've learned is there's usually a threshold, meaning that before surgery, they could have as much as they wanted of this particular type of greasy, fatty, sugary food. But after having the gastric bypass, if they take 1 or 2 bites, they may be okay. But if they cross whatever their threshold is physically for their body, then they're going to have dumping syndrome. And so over time, the patient will learn what their limit is, and they will also gain control because they're going to know, my body tells me I can't have that. And so they're going to begin to not take in those types of foods, especially in a quantity that's going to send them into dumping syndrome. So that's why we look at it as a benefit, because we're not here for vanity. We're not here for, looks, although our patients normally do feel better after surgery. But we're here to decrease obesity and to treat obesity at its root cause and to impact those other chronic conditions. The bypass portion limits the caloric intake. That's true. Your body simply will not absorb everything that you eat or drink because it's not coming in contact with the leftover stomach or the first part of the small intestines. There's simply not that surface area that there was before surgery there to absorb. It produces positive metabolic changes in many organs. This to me is the most impressive statement in this entire presentation, because what we know with the gastric bypass is right after surgery, we can automatically begin to see changes in blood sugar levels, in blood pressure levels, because there is metabolic changes, metabolic hormone changes at the cellular level. And even before a significant amount of weight loss, we already begin to see a difference. And for some people, they go home on no blood pressure medicines or no diabetic medications at all, while others may go home on a half dose until they begin to lose a little bit of weight and hopefully put that diabetes into remission, or to either put high blood pressure into remission or at least reduce. I've had many patients have been on 5 medications and now they're down to 1. So we'll know over time with each patient. It is reversible, but it's a very complicated procedure. This is never a procedure that we would say, hey, if this doesn't work out, we can reverse it later. We never go into this procedure with the intention of reversing it later. Okay, that would be a very, very rare instance. I've only seen it once in my many years here, and it was a very unique case from someone who came to us from out of state. And so never look at that as a plan B. Statistically, weight loss is maintained for a longer period of time compared to the sleeve gastrectomy or other procedures. There is a much higher resolution of type 2 diabetes, about 80% with the gastric bypass. It's known as the gold standard treatment for type 2 diabetes. The average excess weight loss, again, goes back to our national group, where we have thousands and thousands of patients in the database that we can run information off of. The average excess weight loss is about 60 to 80 pounds. Now, if we use that 100-pound easy number to look at, if somebody has 100 pounds that they need to lose with the gastric bypass, on average nationally, they could very easily lose 60 to 80 pounds. However, I have seen many patients that have lost 100 pounds or 110 or 120 pounds, depending on how particular they were with their food choices, portion sizes, and again, limiting eating between meals. Risks. Nutritional deficiencies. This is actually true of the gastric bypass and the sleeve gastrectomy. With a sleeve gastrectomy, it's because the stomach size has been reduced. The body cannot produce as much gastric acid. And for things, for example, like iron, your body requires enough gastric acid to break down the iron into a form that the body can easily absorb. But in particular to the gastric bypass, because when you take your vitamins, you're not going to have all of that surface area from the leftover stomach and the first part of the small intestines to absorb it. So you're going to have to throw a lot more vitamins at your body for it to have that opportunity to absorb. So we do worry about nutritional deficiencies, and that's why forever our patients need to be taking vitamins for the rest of your life. Our national group does recommend bariatric vitamins that are higher in potency than over-the-counter because we know statistically patients absorb more from that type of vitamins. Pouch outlet or anastomosis can stretch with noncompliance. So this is not common, it is rare, but there's a potential if someone were to consistently overeat, then that little gastric pouch connected to the intestines could begin to dilate the base of the stomach that where the outlet was made by the surgeon. It could begin to dilate, and then the patient would not feel a sensation of satiety or satisfaction, and they would feel hungry all the time. So that doesn't happen often, but if it does, it's less than like 5%, maybe less than that, then the surgeon can go in and he can tighten that area back up. Okay, so that would be one potential complication. Gastric ulcers, we've already covered with a sleeve gastrectomy. Same medications and things that we need to avoid with that. A suture line leak, again, we've already covered that in detail. Internal hernia, now this is specific to the gastric bypass. Now, if somebody years after having the gastric bypass were to develop abdominal pain, we do worry about an internal hernia. So the way that our patients lose weight is, yes, they lose weight on the outside, but they also lose weight on the inside, that bad abdominal fat. And so as our patients lose weight, there is something called the mesentery. It's like an apron that lays over the intestines and organs in the body. When the surgeon initially performs the gastric bypass, he actually has to poke a hole in this connective tissue to bring the intestines up to connect to the pouch. So when he does, this little hole just kind of sits here, but over time, as the patient loses weight, this connective tissue is also made of some fat content, and that hole could potentially grow larger over time. And if so, if the intestines get caught up in there and get kind of kinked, it can cause abdominal pain. The patient, is doubled over in pain. They go to the emergency room. And if it's determined that they have an internal hernia, the surgeon needs to go in, put the intestines back where they go, and sew this window back to a size that's going to prevent that from happening in the future. That's like 2 to 5% of patients. It's very low. A stricture. This is typically something that we see around 4 to 6 weeks after surgery. And that would be if that area between the pouch and the intestines heals too tightly, then the patient may be calling the office and saying, hey, I was able to tolerate solid food last week. This week I'm struggling with it. I have pain and now it's coming back up. That would be an indication of a stricture. Again, this is an easy fix. This happens in about 5% of gastric bypass patients. The surgeon would need to go in through endoscopy, go down and do a balloon dilatation of that area to open that strictured area up so that it would create an area that is comfortable for the patient to eat, but yet still gives the patient restriction or a feeling of fullness when they do eat. So contraindications, if somebody is a smoker, this is not the time to have weight loss surgery. We need to go ahead and make that first step towards a healthier lifestyle to quit smoking. This does include e-cigarettes, marijuana, nicotine patches, nicotine gum, because specifically nicotine itself causes vasoconstriction, which means the vessels begin to constrict, and it means that it decreases the blood flow not only to your organs, but more specifically to your stomach, which is where we're going to be performing surgery, which can greatly increase the risk of a leak. Our surgeons actually do require a conitine test, which is a blood test to test for nicotine levels before surgery. And so depending on the surgeon, he may require you to be off of cigarettes or other things that contain nicotine for for 6 weeks. Some require 6 months, just depends on the surgeon. So something for you to be aware of. If someone is now pregnant or they are breastfeeding, this is not the time to have weight loss surgery. However, if you've had a baby recently, about that 1 year mark is when the surgeon would consider you for weight loss surgery. So if you hit maybe 6 months after the baby, this may be a good time to start by having that initial appointment with the surgeon with plans of having surgery around your 1 year mark after the baby. If somebody has an untreated psychiatric illness, this is not the time for weight loss surgery. We need somebody to be in a good place to where they're able to withstand lifestyle changes and to be able to work through that successfully. So having said that, a lot of people ask me, well, Amy, what do you mean by that? What I mean is I have taken care of people who've had weight loss surgery very successfully, who have had issues with anxiety, depression, bipolar, schizophrenia, a lot of different issues like that, and we're very successful. But again, they were well managed through therapy or medications. They were able they were functioning very well. So if somebody isn't able to balance that and doing well, then we need first to treat that and to get them in a good place so that they're able to undergo lifestyle changes to be successful. If somebody is an active alcoholic or addicted to drugs, this is not a good time. The surgeons usually require a full year with going through treatment for that and being able to avoid these things to be successful. Remission, that's what I was trying to think of. If somebody's undergoing current treatment for cancer or chemotherapy, this is not the time. Having said that, though, our surgeons do operate on people who have had a history of cancer, who are in remission, and who, through their oncologist, have the approval to now undergo something like weight loss surgery. There are several cancers that are linked to obesity, and this is why we do treat patients who have gone in remission. If somebody is unwilling to make dietary or behavior changes, then that would be a contraindication to weight loss surgery. One of the things I indicated earlier to be successful with weight loss surgery is to use the physical tool, right? I talked about not snacking or grazing between meals. That is a behavior change. If somebody's not willing to change that behavior, then they're not going to be successful with weight loss surgery. So that's why we have to be very upfront in talking to patients and educating them on the things that they're going to have to change to have this be a long-term fix for them so that they can maintain that weight loss long-term. Now let's talk about statistics. And again, ASNBS is our source of truth here. When we look nationally at the statistics to put several of our very common other comorbidities or health conditions related to obesity under control, type 2 diabetes can improve with either of these procedures about 86% of the time. Remission, okay, about 78, and more specifically in our program, about 80% of the time with the gastric bypass. High blood pressure, hypertension, hyperlipidemia, or high cholesterol, about 79% of the time we can put things like that into remission with weight loss surgery. And you may wonder, why not 100%? Well, with high blood pressure and high cholesterol, there is a genetic link. So if you have a family history of either of these conditions, we may not necessarily be able to put you into remission, but you may be one of those patients that goes from taking several medications down to a reduced dose, or maybe just taking one compared to all the handful of medications that you were taking before. Sleep apnea, this is exciting for our patients that are using CPAP or BiPAP machines. About 86% of the time we can put sleep apnea under control or in remission, and we can get rid of those machines. The caveat to that is after 1 year of weight loss surgery, we do need to have our patients retake a sleep study to make sure that you're safe to not sleep with those machines, simply because with sleep apnea, you quit sleeping in the middle of the night while you're asleep. You don't have control over it, so it is a safety thing for our patients. So some things to know about going for your appointment with a surgeon. My philosophy is that if you are choosing to go forward, move forward with a consult with your surgeon, it's simply a specialist visit, and it's your way of going through, not necessarily to say that you're committed to having weight loss surgery, but you're going for a specialist opinion on your specific situation and your specific health conditions. And so I look at it as another way of going and getting an opinion and getting informed getting more information. So that's why I always encourage somebody, if this is something that you've thought about for a while, you're curious to know more information, go ahead and have that specialist visit so that you can go ahead and hear what their specific opinion is on your situation. But some things to know is when you go for your office visit, they will take a very detailed health and medical history, surgical history as well. They want to know all about your history so that they can give you good information. They will want to know what medications you're on, what foods maybe trigger you, or what your eating patterns are. They will want to help you choose the right surgical procedure. They won't tell you which procedure, but just like I have in this presentation, they'll go over things like your reflux, your acid reflux, or type 2 diabetes. They'll talk to you about the statistics and your chances of putting things like that into remission with different types of procedures and guide your decision on which procedure is best for you. Now, this area is usually a sense of anxiety for some patients, so I like to cover this at the very beginning. Psychological evaluation. All of our patients undergo a psychological evaluation. This is a national standard for centers of excellence because we know that this is something that's evidence-based. We know that when our patients undergo a psychological evaluation, that they get good feedback on maybe areas that they're not aware of, or maybe areas that they were, that they need to work on so that they can maximize their success with weight loss surgery. If you have a cardiologist, an endocrinologist, or a pulmonologist already in your life, a specialist, then you will need a letter from them to your bariatric surgeon so that they know that they are aware of your choice to have weight loss surgery and that they are optimizing you with that disease process. So for example, if you have type 2 diabetes, your endocrinologist is going to want to get your hemoglobin A1C under the best control possible, because we know that if it's well controlled, then it's going to decrease your complication rate and your length of stay, and overall you will recover better after having weight loss surgery. That's why that's important. If you already have had a sleep study and you're on a CPAP machine, that's great. But if you've never had that done and they test you in the office and you're symptomatic for this, they may recommend that you have a sleep study. This is not a bad thing. A lot of times these studies can be done in your house at home, the comfort of your own home. And if you don't have any one of these health conditions that would make you a good candidate for weight loss surgery, then again, this is a good thing to go forward with, because even if you were, if the report showed that you had mild sleep apnea, then this may be the condition that qualifies you as a candidate. Primary care physician, this is really important. If you don't already have a primary care physician that you see, let us know, because we can make recommendations for you for primary care doctors that we know are very supportive of weight loss surgery. We want to know that you have someone in your corner should you get sick with something medical like a bladder infection or a sinus infection. We want to know that you have somebody that you can go to for medical things that is going to be supportive of your choice to have weight loss surgery and be able to support you all the way through this journey as well. So that's why that's important. Submission for insurance approval tends to be another area where our patients are nervous or get anxious. I don't want you to be nervous. We have staff in our offices that specialize in this, and this is their job. They can usually quote these insurance policies even by your employer and know the fine print of what your policy requires. And so I don't want you guys to worry about that. That is their job, and they are very good at what they do. Okay, hospital course, what to expect. The length of surgery is about an hour and a half. We do all of our procedures laparoscopically, just like we do when we take someone's gallbladder out. Some of you may have already had your gallbladder out, so you know it's through those tiny incisions, and so our patients recover very quickly. The length of stay in the hospital for about 90% of our patients is one night. So typically they'll have surgery. The next day around lunchtime, they will go home. So that's a very quick turnaround. Goals for discharge, our patients need to be able to drink comfortably. You need to be able to walk. Your pain and your nausea need to be under control, and you need to be able to go to the restroom on your own. That's how we'll know that you're safe and you're ready to go home and recover. So again, laparoscopically is how our procedures are done. There's usually 5 to 6 incisions across the abdomen and down near the belly button. So it's about the size of my pinky nail. And many of our surgeons nowadays are actually doing it laparoscopically using a robot, the Da Vinci robot. The robot is able to articulate its arms in ways that the human hand and wrist cannot do. So it's a very precise procedure. So that's how our procedures are done. It does mean that because we do it this way, that we have a shorter hospital stay, our patients recover faster. It also means less complications. So for example, the gastric bypass that was done 40 or 35 years ago, it is very different today. We have very good outcomes for weight loss surgery because of the way that we do this surgery. We've technically grown through the years and we've perfected these procedures. After surgery, patients are usually limited to 5 to 10 pounds in the first 2 weeks. So that's something that you would need to plan for. And we do limit work for, it depends on your work. So if you have an office job or you have a way that you can get accommodations to where you don't have to lift things, then you can go back to work realistically about 2 weeks after surgery. If you have a very heavy duty job where you're having to lift a lot, then you may be restricted to 4 to 6 weeks. About 4 to 6 weeks, you can go do whatever you want to do. You want to go to the gym, you want to lift weights, you can do anything at that point. So again, because of the way that we do the procedure laparoscopically, we have fewer wound complications and fewer complications in general. So let's talk about the complications. So when we look at this long list, one thing I want to point out, blood clots, pneumonia, wound infections, bleeding, death. That is going to be on any surgical consent for any surgical procedure that you ever do because it's surgery. So these are not specific to weight loss surgery, okay? However, with the caveat to that, blood clots in the legs or the lungs, there is an increased risk of blood clot development due to obesity in general. That's why we have a very specific plan, a protocol that we follow to decrease the risk of this in our population. Now, the ones that are specific to gastric bypass and sleeve gastrectomy is the intestinal leak, which we've talked about in detail. Ulcer formation, we talked about the things to avoid. We've talked about stricture and we've talked about nutritional deficiencies. Now, the elephant in the room that many people worry about is the death rate. Some people say, Amy, I'm worried about dying on the table. Well, the good news is that with weight loss surgery, we have perfected this and the death rate is actually extremely low. So this is one thing I want you to be aware of. For hip surgery, the death rate nationally is 0.93. The death rate associated with having your gallbladder out, 0.7. The death rate associated with bariatric surgery is 0.13. While all three of these procedures are considered safe, the death rate is considered very low, less than 1%. You can see here that bariatric surgery in particular is actually safer than having your gallbladder out. And again, many of you have already probably done this, or everybody knows somebody who's had their gallbladder removed. When we take that into consideration, if you share that you're thinking about weight loss surgery with your friends, families, coworkers, some people are going to tell you, isn't that drastic? Are you even a candidate? Like, are you even heavy enough to have weight loss surgery? Isn't that dangerous? Well, the fact of the matter is that when we look at the fact that we can treat anywhere from 40 to now we're hearing even 60 other chronic health conditions, and we can reduce premature deaths by 30 to 40%, adding anywhere from 7 to 9 years onto somebody's lifespan, and yet the death rate is less than having the gallbladder out, then very clearly the benefits significantly outweigh the risk. And again, ASMBS is the source of truth. That's where you can go look up these statistics here. Follow-up care. It is very important for our patients after surgery to have long-term follow-up care, not only with their bariatric surgeon, but with a dietitian. Here in our program, our patients can see a dietitian forever, as many times as they need to, for free. That's a benefit of our program. So those are free. We do have counseling. We do have a full-time therapist embedded in our program. He helps us with support group, but he also counsels individuals and does some family and group therapy as well if needed. Those things are very important to the success of our patients. We offer free cooking classes, exercise classes, and we also have a clothing closet where our patients can shop for free. All of these things are built into our program so that we can help to support our patients every step of the way. So there's some other things here about taking vitamins for the rest of your life, making sure you get enough protein, you get your daily fluid in, you find some form of physical activity that's important to you. But I'm not going to go into detail because our dietitian is going to speak on this here shortly. So again, these are the many benefits that you have in our program. I think the things I haven't talked about is the many support groups that we have in our area. Just like this class that you're listening to on YouTube, this is an open channel, a public channel. So if you'd like to check out the other videos, you can see how we support our patients through our support groups and classes. We also have a closed Facebook group so our patients can go and they can get the support not only in our program, but from other patients that have already been there, done that. Okay, so here's some pictures of some things that we offer. This is our Bari Boutique where our patients can shop for free. Our patients can come in and see the dietitian and also look through many recipes that we've taught through our time. So if anybody has any questions, you can chime in by typing over to the right of your screen, or you can respond to the email that you've received today as well. So I'm going to turn the presentation over to Giselle Cram. She is our dietitian here in our program. She's going to go over those dietary changes that are necessary to make this a long-term solution for you. After she speaks, you will see some brief videos from our surgeons so that you can get to meet all three of them. And then what I'd like you to know is that you can call us here at our program at 770-219-0446, or you can reply to the email and let us know how you would like to move forward in our program. So I'm going to turn this presentation over to Giselle.
Hello, good afternoon. My name is Giselle Cram. I'm one of the registered dietitians here in the hospital-based program. So I'm going to go over the nutrition piece. One of the things that we make sure to help our patients learn and understand is that after weight loss surgery, because the amount of food that you're going to be able to eat at a time is not going to be as much anymore. We want to focus on quality over quantity. So every single bite that you take in, we want to make sure that it has the most amount of nutrition possible to not only help you with your weight loss goals, but keep you healthy, prevent vitamin and mineral deficiencies, make sure that you get your protein in. So the dietitians, we're all very thorough on teaching our patients how to do that exactly. Some of the things that you may hear are choosing lean sources of protein. So sources of protein that don't come in with a lot of the fat content. That way you get that protein without the calories. So that's one of the things. We talk about easier to digest animal proteins, especially shortly after surgery. Your digestive system is almost you can say it's a new digestive system, which has to get used to the textures of foods. So things that are easier to digest are going to be the ones that we're going to recommend initially until you are able to tolerate tougher textures and progress to tougher sources of protein. So some examples are fish, seafood, poultry, things like stews are going to be easier to digest shortly after surgery. Another thing that you'll hear us talk about is to reduce. We're going to teach you how to reduce the intake of simple carbohydrates and increase the intake of complex carbohydrates. And what these are, your simple carbohydrates, you want to think about mostly highly processed foods. So for example, your white rice or white sugar or white flour, which has been processed in a way that it no longer has all that fiber. When you think about a whole grain, for example, that's going to have the fiber content in it. It's going to have more nutrition in it as well. The best sources of complex carbohydrates are going to be your beans, legumes, your non-starchy vegetables, your fruits. So those are the ones that we are going to encourage you to consume more of. The non-starchy vegetables is just a fancy word for those very low carbohydrate vegetables like your carrots, bell peppers, cauliflower, eggplant, tomatoes, cucumbers, zucchini, squash, okra. The list is very long, so there's a lot of options. I find that some patients don't like a variety of these types of vegetables because they haven't tried them cooked in different ways. So as Amy explained, we have the cooking classes, the monthly cooking classes, and we have the recipe wall. And our hope is to teach you how to incorporate these foods and try them cooked in different methods. A lot of patients, when they try something cooked in a different way, they may say, you know what, this actually tastes a lot better than I thought. And they get their palate used to these vegetables. It's important to like them. They're an important part of long-term success. Fluids is super important to stay hydrated. After surgery, you won't be able to gulp a lot of liquid in one sitting, so you just have to get used to sipping throughout the day to get the hydration in. The dietitians will teach you examples of all the zero-calorie, sugar-free beverages that you can choose from so that you stay hydrated, but you have options and you don't feel like you just need to drink plain water if that's not something that you like. So we'll show you all the different brands and you're going to feel like you're really going to have a lot of options. Here is a visual of what a healthy plate looks like before surgery, where the focus is on consuming a lot of those low carbohydrate vegetables that I mentioned earlier. Here, a quarter of the plate is protein, a quarter of the plate your whole grain and your starchy vegetables, like your potatoes, for example, a small serving of fruit, a small serving of low-fat dairy, and this plate is about 9 inches in diameter. Now I'm going to show you a picture of what a healthy plate looks like after surgery. The first thing I want you to know, it's going to be a smaller plate. This is going to be about 6-inch plate, which is going to help with portion control. Of course, it's going to be smaller portions automatically with a smaller plate. And now the focus, as you can see, half of the plate, instead of being covered with the vegetables, is covered with the protein, because we want to make sure that you get in the protein that you need for proper wound healing, to keep your immune system healthy, to avoid a lot of muscle mass from the weight loss. So we want to make sure that you get in your protein. And then the other food groups, they're still important. It's just that they're not going to be as much in quantity compared to your protein intake. But your vegetables, your low carbohydrate vegetables, your starches, and your fruit are also part of the plate, but they're going to be very small portions compared to your protein. Protein supplements are the protein drinks or protein shakes that you've seen around the market. Those are going to be the primary source of protein for patients shortly after surgery, because right after surgery, you won't be able to transition right away to, for example, a chicken breast. You're going to have to drink fluids first and then transition to pureed or soft solids and, slowly transition. So the protein supplements are the primary fuel source of protein right after surgery. Whey protein isolate is going to be that first and ingredient that should be listed in the ingredients list. That's very, very important because we absorb that one really, really well. The dietitians, what they're going to do is help you figure out all the different brands, flavors out there of protein supplements, again, so that you feel that you have options. You don't feel that you're drinking the same thing over and over again. We want to make this healthy eating as varied and exciting as possible. So there are a lot of brands out there. There are also a lot of very not so good protein shakes. So that's where the nutrition education is going to be so important, to make sure that you're choosing the right product. It's not going to be just about making healthy food choices. We also, dietitians, we focus a lot on helping you establish a new healthy routine, healthy habits, because a lot of time unhealthy choices happen not because patients don't know what healthy foods are. Unhealthy choices oftentimes happen because of things that happened before. Maybe you were running late in the morning and you just grabbed a bar that maybe is high sugar, low protein. That's just, it was easy, it was convenient, and that's why you made that choice. If you would have had time to cook a really nice breakfast for yourself, then you would have made a healthier choice. So we try to help you figure out what the barriers, what the challenges are, try to overcome those barriers so that you can actually follow through the healthy eating plan, regardless of your schedule, regardless of what's going on in our lives. So we teach things like eating slower, chewing more, which helps with portion control. We teach about avoiding distractions when eating. So instead of eating in front of the TV or looking at your phone while you're eating, we recommend our patients to sit down at a table and focus all their attention into the meal time. So things like that really help. Planning and portioning out meals. So we talk a lot about meal planning, different tips and strategies to help you meal plan successfully. Mindful eating is something that we talk about a lot. What we want really is to help patients be more aware of the choices that they're making, and not just the choices, but why are they making those choices. Oftentimes, a lot of patients find it helpful to keep a food journal where they write down, whether it's in a piece of paper or journal or on a phone app, they write down the foods that they eat. And I like to tell patients to also include their mood or how they're feeling or what time of day was that meal, or even the location. Where were you when you had that meal? Oftentimes that gives us a lot of clues as to what's leading to these unhealthy choices. And then when we become more mindful about that, we can actually make a change. But if we don't realize these things, then how are we going to change? So being mindful is the first step to positive change. As Amy mentioned before, preventing vitamin and mineral deficiency is going to be super duper important. Multivitamins and other supplements are going to be necessary on a daily basis to prevent vitamin and mineral deficiency. The last thing that we want is for patients to develop a deficiency and then take the vitamins for that. No, we want to prevent. So in order to prevent, our patients need to take daily vitamin and mineral supplementation. Things like a multivitamin, calcium, vitamin D, a B complex, iron, vitamin B12. These are the ones that you're going to hear a lot about in the clinics, and we would explain specifically why. That is all from my part as well. If you have any nutrition related questions, please comment on the right side of the video or send Amy an email. Respond to the email where the link is, and we can answer those questions for you. Now we'll show you some videos of our surgeons.
My group wanted to be a primary care doctor like my dad, and realized when I was in medical school that I really liked operating. So I get to have the best of both worlds in a lot of ways. I get to do general surgery, very refined, very specific type of general surgery, but I also get that long-term care and follow-up with the patients that I was looking for when I was growing up. But we get to experience as bariatric surgeons, patients seeing diabetes go into remission, or blood pressure being controlled without medicines. We get to go walk Disney World for the first time, from the front entrance to the back with their grandkids or kids. That's really cool. And you don't get to have that experience with a lot of other types of medicine. So I love it. The Northeast Georgia Medical Center is a great place to have surgery. One, we do meet the national guidelines for Center of Excellence. We've consistently done that for a very long time. The nurses are incredible. The anesthesia staff, the people that make this possible, do a great job. It's not just the surgeon being safe, all the parts of the puzzle fall into place, falling well. What I would tell a patient who's considering bariatric surgery is to learn. Learn as much as you can. Talk to friends, talk to family, go on the internet and talk to some virtual people. But at some point, sit down with a surgeon you feel comfortable having a relationship with, and really do a deep dive on your own personal history. Do a deep dive on what your goals and aspirations are. The surgery itself is not a finish line, it's a starting line. The starting line for the treatment of a chronic disease, which implies chronic ongoing care. So if you feel comfortable with that physician, with that surgeon, that you can see them for the rest of your life, that's the first step, I think, to having a successful surgical event.
Bariatric surgery can be a great option for someone who is morbidly obese because we're going to have good outcomes and we're going to be successful. A lot of these patients have tried other things to lose weight, and they're skeptical because they've tried it, they might have lost the weight and they've regained it, and they want to know why this is different. Well, this is different because we're going to provide them with a tool that will allow them to continue with this weight loss journey long term. We're going to teach them how to use the tool, and we're going to follow. Our discipline of bariatric surgery is a discipline that we can prevent so many diseases by treating this one condition, obesity. And in treating that one condition, we can prevent that renal failure from the diabetes because we can send diabetes into remission. So this is a very powerful discipline. We build long-term relationships with our patients. The follow-up is key to long-term success with bariatric surgery. I finished my training in 1998, and I spent 4 years in the Army doing trauma, as well as doing bariatric surgery. I did start a program at Fort Campbell before joining practice here in Gainesville. So I've been here since 2002, and I currently practice 99% of what I do is bariatric surgery. I do very little of anything else. So this is what I do. I guess the best part about being a bariatric surgeon is just knowing that you have a powerful tool, knowing that when that patient shows up in your office on oxygen with a walker or a wheelchair, knowing where that person is going to be 6 months later, knowing that you can get that person off that oxygen, and get that person out of that wheelchair. That's the fun part of my job.
There's one more doctor. I'm sorry. I'm trying to get that for you. There we go.
My name is Alex Wynn. I'm a bariatric general surgeon. Been practicing.
Sorry, having some trouble there putting that video on for you.
My name is Alex Wynn. I'm a bariatric general surgeon. Been practicing in the Northeast Georgia area since 2008. I like several things about bariatric surgery beyond just the surgery part. I get it that when patients walk through the door, they're taking a huge leap of faith, trusting you with their life and their well-being. My best advice to any patient is always do your research. Understand the different surgeries, understand who you're considering to do your surgery, and understand where you're having your surgery done. But the one thing I always tell patients is don't do it for anyone else. You have to do it for yourself. Whether you're motivated by having to care for a young child, or whether you're motivated by not wanting to have your second heart attack before you turn 40, whatever it may be, you have to do it for yourself. I get asked a lot on what my underlying philosophy in taking care of patients would be. Back in my early days of training in surgery, I had a really wise surgical attendant who taught me the following rule. What's never failed me is that I live by the philosophy of treating each patient as if they were my mother. I always ask myself, and it has always steered me in the right direction, that if that was my mother, the patient was my mother, how would I want the physicians to take care of my mother? And using that as an underlying tone of approaching all patients, whether they're bariatrics or general surgery, it's never failed me.
All right, guys, that is all that we have for you. Again, if you have any questions, remember that you received an email. Please respond to that email with any questions, and we will absolutely answer those for you as quickly as possible. Bye. Oh, good.